So welcome. We look forward to providing tools and resources to all today and for the next 3 weeks. I'm honored to partner with FSU's College of Medicine with Nicolette and her team supporting the great work through the GWEP, and with Dr. Gloff, not only our subject matter expert, but a true partner in the delivery of care to the geriatric population served. My name is Deanne Marasco, and again, thank you so much for the time today. I'm the Health System Director for the Alzheimer's Association for the entire state of Florida. My goal is to work and support health systems in the effort to increase accurate and early detection of dementia and to improve quality of care delivered. We focus on 4 areas: helping to improve health outcomes, enhance the clinical experience for those living with dementia and their caregivers, reduce the burden on clinicians, and manage healthcare costs most effectively. We know that you're doing a good job assessing your patients during the annual wellness visit and using the screening tools for cognition. We want to support your efforts if it's suspected the person is experiencing reversible or irreversible cognitive decline. We also want to support both the patient and their caregiver in providing tools and resources throughout the stages from annual wellness visit, mild cognitive impairment to Alzheimer's and all other related dementias. It is reported that 9 of 10 primary care physicians want further guidance on cognitive assessment process. This guidance includes which assessment tools could be used, how to use them, which patients really need to be assessed, and what to do when an assessment indicates possible cognitive impairment. And we'll be sending additional resources and tools following each of our sessions. We were going to put them in the chat box, but we thought it would be better to send them following the meeting. So our goal, we want to ensure primary care is adequately prepared to provide dementia care. This is especially critical given a severe shortage of dementia care specialists. In addition, we want to consider how primary care physicians are supported within the health system to provide robust quality care. Demands for dementia care is increasing, and primary care really are about to be under siege. We also know that you lead the way in timely detection and diagnosis, and we want to aid and support you along the way. So the next 3 sessions will be designed to provide no more than 30 minutes, offered live, and then we will have this recorded that you can have on demand. And we will also include a case study. So we'll break down the importance of timely and accurate diagnosis, what to do if cognitive decline is suspected, and increase not only the confidence to diagnose, but the support and assist and plan for future of those living with Alzheimer's and other related dementias. And so I am going to turn it over and allow Dr. Gloff to share his screen and to provide the presentation. Dr. Gloff.
Great, thank you. We'll get our sharing going from this end. And today what we're going to do is talk about diagnosing that individual with dementia. And this is really going to be preliminary, the first steps that we're going to take to do that. And so certainly you've got a lot of folks where you'll be doing routine screening. And when you're doing screening, it's not because something has necessarily triggered anything, but there will be a lot of times when you will be concerned about a patient. And there are a variety of things that tip off either you or your staff that there may be a cognitive issue. So one of the things is you'll have somebody who will repeat themselves multiple times during the exam. And you've all seen that. You're working with them and they tell you something that's going on at home, and then 2 minutes later, they tell you the exact same thing. That really is a key that, hey, there may be a problem here. It may be more than they're just a little bit distracted. Certainly anybody who forgets appointments, that's a big deal as well. These are very important aspects of life for our older adults. And you all recognize that this population, when they go to a party or they go to an event, or even if they're just going to lunch with some friends, one of the primary topics of conversation, it involves us. It talks about what their health issues are, what doctors are scheduled to see them, about what things. It becomes a very important part of their lives, and they put a priority on it. And you have to recognize that that priority is something that usually precludes them from missing appointments with you. Now, there are individuals who have reasons because of transportation or whatever, but most of those folks will call if they have an urgent issue where they just don't get the ride they were counting on. They may not call until afterwards, and you call and then they'll explain, yes, I had a problem with the ride. However, if they miss an appointment, it's a big deal, and it ought to be a flag, and you want to follow up on that and maybe do some cognitive testing subsequently. Certainly, if you're in there with family members, and oftentimes we're in there where you have family members who are with the patient when they come in. It may be the spouse, it may be a daughter, it may be even a niece, or sometimes it's a caregiver. But the bottom line is when somebody comes in, and it usually is a family member in this circumstance, when the family member's answering all the questions, you should be a little suspect that there may be a reason for that happening. And when you really work with the family member and have them stop answering questions, a lot of times it will reveal that there are some real issues with the patient that you have in front of you. Certainly, frequent phone calls to the office, particularly about the same issue when it should have been resolved already. And a lot of times as the primary caregiver, you don't actually have that interaction. It's the receptionist or it's one of the nurses in the office. But you want your staff to be aware that those kinds of repeat calls, they're not just annoyances for the staff covering the same thing over and over again. They're flags, and they need to bring that to your attention as the healthcare provider. And then there are some problems that you may identify that are just different for the patient. Certainly weight loss, if they're having problems in terms of shopping, those kinds of things, that often happens with people who have dementia. The other key is change in personality. The individual who comes in and is always well-groomed and now comes in, they're a little disheveled, they don't have everything just properly aligned, they don't have their clothes coordinated. Those are all things that should be flags to do a little more investigation in terms of cognitive function. Even change in mood. So the person who's usually pleasant, who comes in and is particularly grumpy or even nasty with your patient, your staff, those are folks where you want the staff to be aware that that might be something that reflects early cognitive decline, and you want that to be brought to your attention so that you can do the additional screening. Now, when we talk about screening, there are some basic things that we want to evaluate. Keep in mind, really what we're doing is we're looking for reversible causes of memory loss or reversible causes of cognitive changes. One of the best tools to use, and a very quick and easy, simple tool, is the CAM, Confusion Assessment Method. That's just basically going over 4 different properties. One, you're looking for an acute change in mental status, and it's fluctuating. So they may be pretty good 1 minute, and maybe an hour later you come into the room and they're a little more confused, a little more disoriented. Also, people who have delirium, and that CAM is really for assessing delirium, look for inattention. When you're talking with them, they may stay focused for 30 seconds, maybe a minute, and then they have trouble staying with you as you're having the conversation. Those 2 things are very, very important in terms of making the diagnosis of delirium. The last has to do with either disorganized thinking or altered levels of consciousness. And these folks actually can sort of drift off a little bit. They seem particularly groggy. They tell you they didn't sleep very well, or maybe they don't tell you they didn't sleep very well, but you're wondering whether they're having trouble with sleep. And they go from one place to another in terms of their thinking. They can't really focus with you. They start to talk about one thing and then go off and talk about another thing. These are clues. And to have a diagnosis of delirium, you have to have the inattention, you have to have the change in mental status, and then either the disorganized thinking and or the altered level of consciousness. It's important to look for those things. I recently had a patient in our memory unit who actually was admitted with dementia. In fact, had been in the acute hospital, had gotten guardianship because a judge was contacted. Physicians identified this individual as demented, and we got them and they tested positive on the CAM. And lo and behold, after a week with us, cognitive function started to improve. And this gentleman actually turns out to be fine right now. But because people made a mistake in terms of not recognizing delirium, which sometimes can last up to 6 months, but because they didn't recognize that, this guy got a court-appointed guardian, is in our memory unit, is perfectly fine now to go home. But now we've had the state physicians coming in to do the evaluation again, report back to the judge. The judge now has to take care of this and then allow the guy to go home. In the interim, he's been in this memory unit and he's actually fine mentally. And so he's been working on trying to get his bills paid, getting his checkbook from his home, all these things that he can't do because he's confined to this memory unit that we have. So be aware that that's a really good place to start and look for those features. There are other tests that are out there looking at cognitive function that are very helpful in terms of identifying dementia that may not be really apparent when you're having some really standard conversations with individuals. So Trails B, for example, and I'll talk about that, but it's basically going from a letter to the number, to the next letter, to the next number in sequence. And I'll go through that. Most people can get through that pretty easily within a few minutes. In individuals who have dementia, it can be very challenging. There are other tests that are out there like the Montreal Cognitive Assessment or the MoCA. I'll show you that in a minute. That is something that is now copyrighted, and so technically you're not supposed to use it unless you have a license to use that. But it is a test that has been standardized. It's pretty short, easy to administer. It actually incorporates the Trails B among some other things. And that's a screening test that can be administered even by the staff. It doesn't have to be administered by the primary provider. A really quick test that also is very revealing is something called the mini-cog. The mini-cog is a quick 3-word recall evaluation and a clock task, and I'll go through that in a minute. And then there's a test that is commonly used called the mini mental state exam. This is, or the Folstein mini mental state exam. This was developed by Marshall Folstein. Most people know this, but it is not a good test for screening for dementia. So you want to be aware of that. It's a very good test for monitoring progress in dementia, but it's not your best screening tool. And I would recommend not using that alone as a screening tool. So here is a clock, and this is basically the clock task. You have a circle, you ask somebody to put a time in there. The time that you ask is for 10 minutes past 11. You ask for that time because to be 10 minutes past 11, you have to recognize that the 2 represents 10 minutes. And you'll note that this individual here put the hands on the 10 and the 11, got the numbers pretty much in order in terms of where they should be, but this is certainly not a perfect clock task. And this individual ended up having problems with executive function, and the more detailed testing revealed that in a much greater way. And he continued to progress. But this was the only abnormal thing that he had. He actually did very well on recall. He did very well in terms of orientation. And when we did this test, that's where we were able to determine he had some problems. Here's the MoCA. You can see up at the top here, this is part of the Trails B test. And I'll talk about that in a minute, but you can see you start at 1, then you go to A, then to 2, the next would be to B, etc. And it goes through I, J, K, L, and all the numbers that accompany that. And they should be able to do that within a few minutes period of time. They get time to do it, and there's a particular way to administer that. The instructions are easily available for anybody who gets the Trails B information. And that's a good screening test to use for individuals, and it picks up dementia relatively early. The naming is part of the MoCA. It is somewhat culturally specific. And so you'll ask people to name the animals, and when they do, if you've never seen a camel or you've never seen a rhinoceros or a lion, obviously that's going to be difficult for you to name, especially if in your background you don't have interactions that would help you to understand that. So it is somewhat culturally dependent when we talk about the animals, and different cultures will actually use different animals, and it has been standardized to use them. There's our memory questions, there's attention, language, abstract thought, and these all are things that are out there that cover the various domains of cognition and help in terms of us assessing whether or not an individual has dementia or not. Here's another example of the TRAILS B. Again, this is the sample, so it's not the entire TRAILS B, but it makes it very easy to see how things would go. You start here at the beginning with 1 to A, 2, B, 3, C, etc. And we can do that pretty quickly, but you'll be surprised to see individuals that you thought were pretty intact cognitively who actually can't do this. There are other tests that are out there. Here's the functional assessment questionnaire. I didn't really talk about this very much, but it is a scale that is out there. It's a very brief, easy one to administer. Talks about various functions, predominantly around instrumental activities of daily living. And when you look at these things, it has actually a scoring system depending on somebody's capability in terms of doing each of the tasks that are described here. On a scale of 0 to 15, a score of 5 or more suggests that somebody may have dementia and may require some additional testing. 9 is a traditional cutoff in the literature, but anybody who scores a 5 or worse is probably going to have problems. So our goal really is to look for reversible dementias. Probably less than 20% of dementias are reversible. Some of them are things that we recognize pretty commonly, but you always want to look for reversible dementias because they are treatable. These are things that actually can get somebody back to normal if you identify it. If you just assume somebody has dementia, you will miss these. And I get quite a few patients who have issues with some of the things here that are not picked up and they're just assumed to have Alzheimer's disease or some other dementia. So one of the things that we talk about commonly is hypothyroidism. Individuals who are low in their thyroid status have a terrible time with memory. For all practical purposes, you would think they had Alzheimer's disease. Yet when you correct their thyroid function, that memory comes back and they actually function quite normally after that. Normal pressure hydrocephalus is another one that is commonly missed. We have the triad that everyone discusses where you have people who have some cognitive issues, they have issues in terms of their gait, they have some urge incontinence issues, and those are very common problems among older adults. Nonetheless, if you don't think about NPH, a lot of times you will miss that. Mm-hmm. And I've had quite a few patients who have had NPH. In fact, just had a patient come back from Cleveland. We sent them up to Cleveland to get a shunt placed, and they had him come back, and he's much better cognitively now that he's had that shunt placed. You may not be able to do it in a rural area where you don't have access to a neurosurgeon, but you do want to be aware of it. And when you do make the diagnosis, you may have to send them out to get that shunt placed, but it can make all the difference in terms of their function, both physically and cognitively. Certainly medications are another thing that we need to consider. And then there are some more rare issues, meningioma, particularly if it's large enough to cause some pressure on the brain. A lot of times there will be focal deficits with meningioma, but not always. And then infection is another one that can lead to a lot of mental status changes, particularly in your older adults. The key here is that these are curable, and so you don't want to miss these. In essence, basic laboratory testing should be done on everybody where you have a suspicion that they may have dementia. And these are pretty simple, routine things that we do, CBC and a CMP on all of them. That gives you a lot of things to assess in terms of electrolyte disturbances, glucose changes, infection. A lot of those things will come out when you do some of these basic lab tests. Thyroid function studies, predominantly at TSH, because you're looking for hypothyroidism with most of these individuals if they're going to have mental status changes. And then you do occasionally have somebody who has a nutritional deficiency like vitamin B12. I actually don't get a lot of people who have dementia associated with vitamin B12, but I do have some folks who have deficits associated with B12, particularly vibratory sensation loss. If you have any question, if the B12 level is less than 500, go ahead and order your methylmalonic acid level, and that will help confirm whether or not that's truly a low B12 level or not. And then based on history and physical exam, you may want to do some other tests such as HIV testing or tests for syphilis. In terms of normal pressure hydrocephalus, that is one of the reasons why we order imaging studies. And so I didn't talk very much about imaging studies up until now, but just to make everyone aware, the recommendation is really to do some imaging study on most patients that you have that have some cognitive deficits that you pick up in your screening, or where you have a suspicion that they may have dementia. You do these because you, again, are looking for reversible causes, but a lot of times it can also give you a clue in terms of the etiology of the dementia, even when it's irreversible. You can see here in the imaging where you've got the individual with large ventricles. Now this has pretty normal sulci over here, so this is a relatively younger individual. A lot of times you'll see very deep sulci, and you won't see nearly as much expansion, but if you get a good radiologist, they'll tell you that the ventricle is enlarged disproportionately to the amount of brain atrophy. When you see that, you definitely want to follow up and think about NPH in your older adults. Generally, the workup is going to involve a spinal tap, either to do a ventriculogram or just to take some fluid off and see if they improve over that period of time, the next 24 to 48 hours after you remove a little CSF and lower the pressure. This is usually done on an NPH unit, and so that's not commonly available in most rural settings. And in fact, even in some of the more urban environments, certainly down here in Naples, we don't have anything like that that we can do here in this immediate area. And so when I have somebody work up, I need to send them maybe over to Miami, or I send them up even beyond Tampa. As I mentioned, the one case I sent up actually up to the Cleveland Clinic. There are other changes you'll see on MRIs. So you may see some white matter changes that tells you possibly vascular dementia. Depending on where it is and how much it is, you might think about frontotemporal dementia if you see a lot of degenerative changes in the frontal temporal areas. Lewy body dementia, you can see on the left here, you have somebody with normal hippocampi here, both sides, compared to the Alzheimer case, which usually has the hippocampal area and a lot more cortical loss. And that can help with the diagnosis of Lewy body dementia. Also, history helps with this. These individuals oftentimes have extrapyramidal side findings. Sometimes people mistake that for Parkinson's disease. A lot of times their alertness varies a little bit. And you'll find that they also have a lot of visual hallucinations. And sometimes they have activity when they're sleeping. So these are folks that when they have a dream, they'll be running in place. Spouse oftentimes will complain that they're so restless in their sleep, or that the spouse gets hit by the person who you're evaluating. That history oftentimes will tell you about Lewy body dementia. There are other tests that are out there. So this is an amyloid PET-Scan that are out there. There are a variety of tests looking at amyloid deposition, looking at amounts of precursors for amyloid. Generally, this is not something you want to do in your regular practice. This is out there. You can see here that you've got this Alzheimer's disease patient, lots of amyloid here on the left, but you also have a normal patient who has lots of amyloid. So this is not a particularly, certainly not a pathognomonic test, and it's not a test that generally needs to be done in a clinical practice the way that you have it set up. So if you get a CAT scan or an MRI, that's really all you probably need to do in terms of assessing your patients with that you think may have dementia. So in summary, we talk a little bit about dementia in terms of the assessment tools that are out there. There's a host of them. Pick something that is standardized, that is quick and easy to administer, and gives you a good screen so that hopefully as the primary care provider, you can have some of the nursing staff or other individuals trained to do this, administer it, and then report to you while you see the patient in the office. There are certainly imaging and lab tests that you want to get. We talked about those a little bit. The key here is searching for reversible causes. And next week when we talk, we're going to talk about what to do with those data once they come back to you. So after you get the blood work back, after you get some of the imaging, we'll talk about some of the findings and then what steps you want to take afterwards to make sure that you resolve the issues, how to do that, and if it does turn out to be an irreversible cause, we'll talk about some of the things that you want to do to pursue that and provide support related to the diagnosis. So that gives us a summary. One of the things I would like to do is give a little bit of information related to a case and then have a discussion. But before I do that, let me just ask if anybody has any specific questions related to what we just discussed. Remember to unmute yourself if you want to ask it verbally, or you can use the chat session if you want to do that.
And so I can answer that, Doris. This is Deanne. I am actually recording this. So I will have the recording of this presentation for you all.
Okay.
It sounds like it might be like a checklist for the front desk staff to like behaviors to notice, to flag the provider. They probably don't need all of the other slides. But that first part is really what you're looking for, Doris. Yeah, we can figure a tool out for that. Thanks.
All right, let's briefly talk about one of the cases and see how that relates to what we just presented. So we've got here a 91-year-old. It's a female who comes in, independent living apartment. She's in a senior community. Your main questions you want to ask about this patient are the symptoms, complaints related to MCI, mild cognitive impairment. That's a good term to use because it's not nearly as scary as Alzheimer's disease or dementia. And when an individual has cognitive impairment and you talk about that, it's a good term to use because you're doing a workup and it allows you to interact with the patient and family without them getting overly upset that they have an irreversible issue before you even know whether or not they do. Trying to lower this screen here, and let me try something else. There we go. So as you go through your checklist, you'll look to see whether or not there are behavioral issues that have come up in this particular individual, and you find that they have issues related to insomnia or wandering, things like that. Those are pieces of information that are going to be really helpful. You also want to identify whether they have any agitation or aggression for two reasons. One is because it helps you identify that there's cognitive changes, but the other reason here is because it is something that is likely to lead to an individual having to change their environment, change their living situation. Incontinence and agitation are the two main reasons why somebody will find themselves in a nursing home if they have dementia. You want to take a look at other diagnoses that the individual has. And so as we go through the history, patient recently transitioned her care from out of system providers to her community's on-site clinic for independent living. And that happened after a hospitalization with an SSRI-induced exacerbation of her SIADH. And so if she's got inappropriate ADH secretion, then you recognize that that can have an effect on her electrolytes. Because of that, she can end up with mental status changes. That is certainly something that's potentially treatable, so you want to know about that. She continues to have anxiety and agitation. This presents as frequent and spontaneous in terms of its onset, but it can cause her to pace frantically or just to stand still, almost like a deer in the headlights. Son reports episodes of frustration, particularly related to the difficulty accomplishing tasks that she could do before and is not able to do currently. So she's not been hospitalized for any psychiatric problems in the past, and that's an important question to ask. And then related to her past medical history, we talked about the SIADH. Hypothyroidism is also part of her history, though, so you want to be aware of that. Hypertension with fluctuations in pressure, particularly as it relates to corrections of the sodium level. And that's a relatively common thing to see. And you also want to take a look at her medications. And in terms of medications, look at that thyroid medication that she's currently taking, and you're going to want to check her thyroid level because that certainly is something that can cause problems as well. There are other medications she's on there. If you look through those, most of those are really not going to be associated with problems in terms of memory or agitation or mental status change. However, I will tell you that the B complex that she's taking gives you some degree of comfort that she probably doesn't have a B12 deficiency. You do want to ask how much she's taking. But if she's taking 1 milligram a day orally, it is unlikely that B12 is going to be the issue here. In terms of medications that she had been on previously, she was on sertraline and Xanax. Those two are both notorious for causing problems, not only because of the SIADH, but also because the alprazolam is associated with memory loss and a number of other risk factors for your older adults. And then the medication she discontinued were medication for her blood pressure. And that oftentimes happens as you get that sodium under control and you get the SIADH treated. Other history that's relevant, she has a history of smoking, but she's quit that quite some time ago. She has a little bit of alcohol. You want to check to make sure that she's not drinking more than that. 2 to 4 times a month, usually those patients are not going to be the ones that get in trouble. But when you have patients that are telling you they're having 2 drinks a night, you want to find out, obviously, how big are those drinks. And it may not be the alcohol that's causing the problem, it's the withdrawal. So when they go into the hospital and they no longer are drinking, a lot of these patients, especially if they go for urgent surgery, will end up going through withdrawal and they have terrible delirium. So be conscious of that as well. Says the son organizes the medications, make sure that the son is there when she's taking them, because if not, then that can be an issue as well. And so be aware of the issues with meds. You'll note here that she had an MMSE perform, that mini mental state exam, and she scored 29 out of 30. Well, that's an excellent score in terms of cognition, but as I mentioned earlier, that's really not the ideal tool. The SLUMS, the St. Louis evaluation scale that's used out commonly and is not copyrighted, is one that's used commonly. The mini cog is another one we talked about earlier. These are very good tools to use for screening. Mini mental state exam, not so much. It has neuropsych testing, and I didn't talk very much about that, but I just want to emphasize that neuropsych testing is an issue for folks if you aren't sure what's going on. If you do your testing and everything is fine, but you still have suspicions, or they have suspicions, or the family has suspicions, go ahead and order the neuropsych test. Sometimes that's difficult to get in more rural areas. A lot of times it'll be a neuropsychologist who will do that for you. It's a 2 or 3 hour test battery, and it takes a long time, but it's very informative and it's good to get as a baseline. But isn't something you should worry about in terms of your screening when you're seeing patients routinely in the clinic. We talked about the labs. It looks like everything is okay in terms of the laboratory testing. Any thoughts in terms of things that you might want to do beyond what we've done so far?
I find in some of these elderly patients, you also have to really check for a urine culture and make sure that a urinary tract infection is not an issue.
Absolutely. So those reversible causes related to any type of infection, that's right on target. So that's a very good point. Definitely something you want to check in somebody like this. Individuals, whether they have dementia or don't have dementia, they are likely to have mental status changes that can exacerbate dementia when they have it, or create a delirium that is often mistaken for dementia. So that's an excellent point. And for some of these older adults, depending how much assistance they give or they get, even something as simple as wiping from front to back for some of these ladies is really important to go over and make sure that they're practicing proper hygiene so that they don't end up with recurrent infections. Really good point. All right. The other thing that you want to keep in mind here is that there is a caregiver involved, the son is involved. And if that individual is coming to the appointments, you want to, or even if they're not, you want to make sure that you communicate with the son to make sure that that individual knows what's being done, what you're evaluating. And then when the results of the tests that you do initially, whether it's the blood work or the urinalysis or the imaging studies, you want to make sure that the son is there as well so that all that information gets assimilated. Also, you want to get input from the son in terms of, is this consistent? Does she wax and wane? Is sometimes she has good days and sometimes bad days? Is she normal sometimes and really unmanageable at others? Those are all important things in terms of the evaluation. All right, before I go on and wrap this up, any other comments that people have or any questions that you have before we turn things over?
No, I'd just like to share a little. I most recently had the exact situation, patient very cognizant with her makeup, her appearance, her clothing. We started noticing when she'd show up for appointments, she hadn't brushed her hair, no makeup. This was very unusual for her. Still driving around town, and we're in a very small town, you know, about 7 miles long, so it wasn't a big danger. But I started calling the son who lives an hour away. Have you been to the house? Do you know what's going on? So sometimes even a little home help visit can see, are we hoarding? Are there groceries in the fridge? You know, things like that kind of can clue you that something's going on. They're not functioning normally.
That's a really great comment. And that is absolutely true. And the staff can have a really big role in terms of identifying these things as well and making sure they're aware, changes in personality, appearance, as you mentioned, getting others in the family that can go and check the home that make sure that there are no safety issues going on, and then making sure that you do that additional workup. That's the trigger for us as clinicians to make sure that we look at, okay, what could be causing this? And in the best case scenario, you find it's a medication or it's an infection, or sometimes it's maybe a normal pressure hydrocephalus, but something that you can identify. And if you can identify something that's reversible, it'll make all the difference in the world for that individual in terms of their quality of life and their longevity. So good points.
And Dr.
Right.
Glock,
Yes.
you know, one of the other questions I have, even with the description you gave, Doris, is looking at and screening for depression. So has there been increased social isolation? Would you say that that is another tool to look at or an indicator as well to rule out?
Yeah, all these changes in behavior really are. Now, I will say one of the things that when you do evaluate depression, we used to talk about pseudo-dementia related to depression, where people who were depressed had a decline in cognitive function. Generally, what we find is that depression can unmask an underlying dementia. And so when you do have individuals who improve after their depression is treated, you want to keep an eye on them because it is likely that that is just masking a depression. And when the depression, a dementia, and when the depression comes along, it sort of lets you know, it's a flag early on that things might be declining further later on. And while you may see improvement early after starting an antidepressant and getting them involved with counseling, you find out in a year later that now you're starting to see those same tools flag again. And so depression is a really helpful thing to identify and to follow up after you do. So good point. Thank you.
Mhm.
All right, let me remind everybody that next week what we'll do is we are going to talk about information that from the data that we accrue, and then where to go in terms of next steps after we get lab results or imaging studies or other things that help us to identify that there is a cognitive issue and what we should do to fix that cognitive issue if it's reversible, and what other things we should do in terms of how we should get support if it's an irreversible issue, and other things that we can do to improve quality of life and safety for our patients when they do have these issues. Most of the time, it really doesn't require us making a referral to neurology or geropsychiatry. A lot of this stuff we can handle as primary care physicians. And I think next week when we finish, everybody will be pretty comfortable with that. Very good. I'll thank you all for your time.
Thank you.
Nicolette, if you want to have a final word there, go ahead, but we'll let them finish up their lunch and get back to work.
Yeah, we will try. We're gonna have a different case for the presentation next week, so we'll try to get that to y'all a little bit more in advance, so you could really take a look at it and come up with some ideas or solutions or things that you're finding in that scenario. But thank y'all for your attention and questions.
Yeah.
Very good. Thanks.
Thank you.